Mike Gibson, Katja Bartholdy, and we're talking about the DECODE-CKD study looking at DAPA in the setting of chronic kidney disease. Talk to us a little bit about why you did this and what you found, Katja.
First of all, thank you, Mike, for the invitation and the opportunity to share the results of the DECODE-CKD trial. So we did the study to understand the mechanisms underlying the cardioprotective effects of dapagliflozin in people with chronic kidney disease or CKD, as we found, as we've seen previously in Credence, DAPA-CKD, and EMPA-KIDNEY. And as you know, people with CKD, they tend to develop hypertrophic hearts, which contribute significantly to their heightened risk of cardiovascular morbidity and mortality. So we hypothesized that treatment with dapagliflozin would favorably reduce left ventricular mass index in patients with CKD.
And what did you find?
Yes. Well, we carried out a randomized double-blind placebo-controlled trial where we treated patients with CKD with either dapagliflozin or placebo and followed them with echocardiography for 6 months, enrolling a total of 222 patients. So the patients had to have an eGFR between 20 and 60, measured twice, of course, at least 3 months apart, or they had to have a urine albumin creatinine ratio of more than 200 if their eGFR was above 60. So this was actually a more inclusive trial than previous trials, including more stages of CKD and also different etiologies like, for example, polycystic kidney disease, which were excluded in both major CKD outcome trials. And what we found was that there was actually a significant reduction in left ventricular mass index, which was the primary endpoint in people treated with dapagliflozin as compared to placebo. And we saw that the effect was consistent across a range of clinically relevant subgroups, such as history of cardiovascular disease, left ventricular ejection fraction, NT-proBNP, use of background medication like RAS inhibitors or loop diuretics, and of course eGFR and urine albumin creatinine ratio, but also the primary cause of kidney disease, such as polycystic kidney disease.
Where do you see this fitting in practice then, Katja?
Yes, a very good question. Well, we already seen the cardioprotective effects, so this is kind of like a proof of concept study where we find the biomarkers. Of course, we can't echocardiograph all kidney patients, but it's definitely something that can help us understand and maybe also include more patients, like, for example, polycystic kidney disease, into these cardiovascular outcome trials, because we didn't find any interaction effects for this subgroup.
Well, always good to see the big randomized trials, but also always good to see the mechanistic studies to really give us the reason to believe the results of these big studies. Katja, thank you and your team for your wonderful work. Thanks for joining us today, and thanks to all of you for joining us here live from ACC 2025.
Thank you for having me, Mike.